Hey everyone, we're just waiting for people to join us. I can see people popping in to the webinar. So we'll give everyone a little mini to arrive and then we'll get started. Alrighty, we'll jump in. Welcome everyone. My name's Jacinta Lenahan. I'm the Health Promotion Team Leader here at Women's Health and Wellbeing Barwon South West. I want to really thank you for joining us to formally launch the report from both sides of the door, community voices and service provider perspectives on sexual and reproductive healthcare in the Barwon South West region. This consultation was completed in 2025, where we asked local women, gender diverse people and healthcare practitioners about their experience accessing and delivering care for SRH. We're so grateful to everyone who participated in the consultation and shared your experience, and we're looking forward to sharing the findings with you all today. I would like to first acknowledge the traditional owners and custodians of the land on which we meet on today. For me, I'm on the land of the Peek-a-Wurrung people of the Maar Nation, and I extend my acknowledgement and respects to the nations that you're all joining from. I acknowledge all Aboriginal and Torres Strait Islander people's resilience, their cultural heritage and continuing connection to land, waters and community across Victoria and Australia. I pay my respect to elders past and present, and I extend that respect to any Aboriginal or Torres Strait Islander people joining us today. For those who are new to our organisation, Women's Health Wellbeing Barwon South West is an independent, feminist, not-for-profit organisation committed to intersectionality, gender equality and best practice health promotion. We strive towards an ambitious vision where all women are healthy, safe and equal. Before we jump in too far, we'll just do a little bit of housekeeping. So we are recording today's webinar and it will be posted on our website for anyone who couldn't make it today or who would like to watch again. This is a Zoom webinar and only the speakers are visible and participants' names or faces are not recorded. Zoom has a live captioning function, which we have turned on for everyone. If you would like to turn it off, you can click the CC icon and deselect Show Subtitle. We invite you to please use the Q&A function for questions and to share any thoughts or comments. And this will be moderated by one of our health promotion officers, Isolda. In terms of language, all information presented today has been collected from women, gender diverse people and service providers located in the Barwon South West. The Barwon South West region refers to the area of Victoria you can see on the map on the screen. The region spans the lands of the three traditional owner groups, the Gunditj Mara, the Eastern Maar and the Wadawurrung, and includes 9 local government areas. Sexual and reproductive healthcare refers to a broad range of services and information across the life course. When we talk about SRH today, we are referring to a broad range of services, such as the ones you see on screen. So from things like contraception, abortion, both medical and surgical, maternal and perinatal health, sexually transmitted infections, chronic conditions like PCOS and endometriosis, education. An important safety note, if you feel impacted by the discussion, please feel free to take a break or do whatever you might need to do to look after yourself. Our sexual and reproductive health is linked with our mental health and well-being and having safe and respectful relationships. If you'd like to speak to someone about violence you've experienced or your mental well-being, Isolda will put some numbers in the chat. Our definition of women for today encompasses both cisgender and transgender women, And when we refer to the word women throughout today, we're referring to all of those who identify as a woman. And a note on confidentiality, all the quotes and information presented today, whilst generously supplied to us, has been de-identified. So as for today's session, I've got the joy of bringing you a little bit of a project background. Then I'm going to hand over to my colleague, Caitlin Hogan, who's going to bring us some consultation findings. And then we're going to hear a practitioner's perspective from Dr. Caitlin Pring from Cardinia Health. Caitlin is a GP specialising in women's health. Then we'll have a bit of time for an audience Q&A, so some dedicated time at the end for you to be able to ask questions to any of our speakers today. We're also joined by Isolda, who is providing tech support and will be monitoring the chat. Thank you so much, Isolda. Let's jump in. So a bit of background to this project. In 2024, Women's Health and Wellbeing Barwon South West engaged Deakin Rural Health and the Centre for Australian Research into Access to map access to SRH services in the Barwon South West. And this project had two objectives. The first was to undertake some spatial mapping and analysis to really understand and identify service gaps for sexual and reproductive health in our region. The other objective was to conduct a literature review to understand SRH access in a regional and rural context. This mapping exercise revealed gaps in primary care access for specific services, such as medical termination of pregnancy and long-acting reversible contraceptives. The mapping also identified areas, particularly the Glenelg Shire and Southern Grampians Shire, where travel times were significantly longer. The systematic literature review provided some insights into the barriers and facilitators of SRH service access in rural areas. Women's perspectives revealed barriers such as limited awareness, fragmented care, negative attitudes, cultural safety concerns, financial burdens, and lack of support systems. For providers, it highlighted barriers such as fragmented healthcare pathways, inadequate service availability, and high costs. Here we've got an example of the spatial mapping that was undertaken through that part of the project. These maps used address level data to map people to their closest sexual and reproductive health service. This map that you're looking at here looks at the services offering medical termination of pregnancy in the region. You can see that the red spot highlights where services are located, and you can see that the local government areas of Glenelg and Southern Grampians in particular are lacking services. So this mapping report, along with a systematic review, recommended that in order for us to further explore what SRH care looks like in the Barwon South West, that we needed to undertake some community consultation with local women and healthcare providers, which is what we've done, and we're here to share that with you today. In order to understand how we think about accessing healthcare, we'll briefly touch on how we defined access. Access to healthcare is multifaceted. There are lots of things that influence whether a person can access care or not. There are also lots of models and frameworks which define and examine healthcare access. The conceptual framework of access to healthcare encompasses a multidimensional view of healthcare access, and this framework was used to guide the literature review as well as our consultation. When designing the consultation survey and completing the consultation analysis, we looked at the spatial and aspatial dimensions of access. When we use the term spatial access, this relates to geographic factors affecting the availability and accessibility of healthcare providers and services. When we use the term aspatial access, this is talking about the non-geographical factors, things like affordability, timeliness, accommodation, so the structure of services, acceptability, the cultural norms of a service, and awareness. And you'll see these dimensions of access referred throughout our summary report and the full report that we're launching today. This consultation here occurred between May and November 2025, and took place over 2 key phases. So our first phase was through an online survey. We had 2 online surveys with both closed and open-ended questions across 5 key service areas. So STI treatment and screening, contraception, abortion, chronic reproductive health conditions, and pregnancy and postnatal care. We had 344 people complete the community survey and 87 people completing the practitioner and professional survey. So then we moved into phase 2, and this was around focus groups and interviews. So we held focus groups and interviews to explore the key issues that were identified in phase 1 in more detail. We held 24 semi-structured interviews, 10 with health professionals and 14 with community members. And we ran 3 focus groups, one based around perimenopause and menopause, one looking at pregnancy and post-birth care, and one with GPs experiencing delivering care. So we had a total of 12 participants across those focus groups. In total, over the last 12 months, we've heard from over 450 women and gender diverse people and healthcare practitioners participating in this consultation. We've had participation from across the entire Barwon South West, and whilst efforts were made to reach a diverse range of voices, we acknowledged that there was limited participation and representation from some groups and perspectives. So, for example, First Nations and cold communities, we acknowledge are underrepresented in this consultation. And you'll see that this forms a further recommendation for our organisation to action. I'm now going to hand over to Caitlin, who's going to share some findings with you. Thank you, Caitlin.
Beautiful. Thank you so much, Jacinta. Thank you for providing the background. As Jacinta said, I'm going to run through some of the findings from the report and the consultation. I won't be able to get through all of the findings that you'll find in the report, but I'll talk to some of the high level and the key themes that we've received. Firstly, I also want to say a very big thank you to those of you on the call today that may have contributed or supported in our consultation. It was a real joy to work on this project, and it was a privilege to be able to listen to your stories, and we hope that, we're able to honour your voices. To talk through the key findings, we're going to use a bit of a case study to talk through the experiences and the key themes that we heard from our participants. So everyone, I'd like to introduce you to our new friend, Wilma. We're going to get well acquainted with Wilma over the next 20 minutes or so. So Wilma, she's 28. She lives in Portland, which is located in the Glenelg Shire. She's pregnant, and she's had a history of pelvic pain and painful periods. Wilma is just one character that we'll meet today. We'll also introduce you to a few others. And just please note that Wilma and the other characters that we'll introduce you to are fictitious characters. They're not real people. They are, people that we've created for the purpose of today's webinar. However, we hope that you might be able to see yourself in Wilma or some of the other characters that we will introduce yourself to, or at least be able to recognise people that you may know, because we think that Wilma's experience is a pretty common experience. And that they are the experiences and the stories that you shared with us during the consultation. I'd also just like to point out the quote that we have here on the slide, and for you to possibly keep that in mind throughout today's presentation. What we heard throughout the consultation is that women's health and sexual reproductive health is still seen as a taboo topic, and that there's pretty outdated social norms that can really prevent and stifle conversation. However, equally, what we did here in the consultation is just how beneficial it is to talk about women's health, not only for ourselves, but also for the broader women and community around us. Next slide. Thanks, Isolde. All right, we're going to go back in time to start Wilma's journey, and we're going to talk about her adolescence. So Wilma is currently 19, and she's, as I said, had a history of painful periods and pelvic pain. There's been times where there's a lot of really heavy bleeding and really painful periods, and that's sometimes stopped her from doing things. So Wilma loves to dance, she loves to swim, but finds it quite hard to do these things during her period. She's had to take days off school due to the pain and has even missed out on social events. She's been to a couple of GPs, but hasn't really been able to get to the bottom of her pain and hasn't been able to manage the pain effectively. A GP originally told her to go on the pill and that'll help sort it out. But it's been pretty difficult to be able to get a GP that will listen to her and not be dismissive of her pain. One GP has just put it down to regular period pain and that she should continue to expect this pain. Eventually, she's found a GP that will listen to her, and that GP has given her a referral to see a specialist. However, that specialist is located in Melbourne. It's pretty expensive to see, and they have a 5-month-long waiting list. Being a uni student in Portland, that's pretty difficult for Wilma to be able to access, and she also would need to take a full day off her part-time job. She's also been given quite a bit of conflicting advice about how to manage her pain. GPs can tell her one thing and just tell her, this is pretty normal, but then she'll go on social media and being given, some entirely different information as well. And it's been a pretty difficult journey to navigate. All right, so Wilma's experience of being, dismissed and having difficulty accessing care locally is exactly what we heard from the participants in the consultation. Firstly, for many of you, it was just difficult to access a GP for any form of, healthcare. This was particularly the case for those in the Glenelg and Southern Grampians local government areas, where we heard some of those participants had to wait up to 8 weeks to be able to see a GP. But it was particularly difficult to be able to see a GP that had an interest in who understood women's health. Many participants ended up seeking care in private practice or were referred to a specialist to be able to get a specific women's health expertise. And for those who weren't able to access care locally and travel was difficult to get to appointments, telehealth was seen as a really valuable option to be able to access that women's health care. Women's pain, women repeatedly told us that they were dismissed by their healthcare providers and their experience of pain was either minimised or just wasn't taken seriously at all. We can see that just under half of survey respondents with a chronic condition felt as though they were given information and support for pain management. Some participants reported that healthcare practitioners suggested their pain was psychologically based and put it more down to a mental health issue. We also heard that women really minimised their own experience of pain and felt like a burden when they were sharing their experience of pain with others. This often meant that women suffered in silence and didn't share their experience with many people. We also know that this issue of women's pain being dismissed is not new, and it's also not confined to the Barwon South West region. We have seen the latest Victorian inquiry into women's pain show that the dismissal of women's pain is widespread right across the state. A key area where dismissal of women's pain was most noticeable and most prevalent was in relation to IUD insertion and removal. So firstly, we heard many stories about how it was really difficult to find a practitioner who would insert and remove an IUD, and many participants had to see a specialist to be able to access this care. And we know that accessing a specialist can be quite costly and also quite time consuming because they're often accompanied with quite a long waiting list. We also heard many stories about IUD insertions being performed without adequate pain relief and sometimes performed without any pain relief at all. However, there is some good news. The Victorian Pain Inquiry also heard similar stories to this, and as a result, as part of the recommendations from the inquiry, they are now providing adequate pain relief during this procedure. So there are 20 women's health, sexual reproductive health hubs across Victoria who will now offer the green whistle as part of this procedure. And we're fortunate enough to have one of these sexual and reproductive health hubs located in our region. So there's one located in Warrnambool at South West Healthcare and the Community Health Hub. And I've just seen Isolde's put that information into the chat there if anyone would like some more information around that service. All right, we're now going to move on. We're going to go back to Wilma, who is pregnant. Hooray, congratulations to Wilma. Unfortunately, it was a little bit difficult for Wilma to fall pregnant. And during that process of getting medical advice, she found the conversation was really directed at her and didn't really include her partner along the fertility journey. She's seeing a women's physio during pregnancy, and this has been great, particularly given her history of pelvic pain. It's really helped with those symptoms as well. However, it's been quite expensive accessing the physiotherapy, as she's accessed this through private practice because the wait list in the public system was really long. She's currently travelling to Warrnambool to access her midwifery appointments and will give birth in Warrnambool. But this is located an hour away, and each time she's seeing someone new during her visits. So again, these are really similar stories to what we heard during our consultation. Repeatedly, we heard that women's physio was described as essential care during pregnancy, but also following the birth of a baby. Many women said that it was really difficult to access physiotherapy in the public system and that they come with, months-long waiting lists. Just 46% of the people that participated in our survey said they were able to access physiotherapy during pregnancy or following the birth of a baby. And most of those respondents said that they had accessed physio through private practice and found it was a really important preventative measure and also recovery measure, but quite costly, and this was not affordable for everyone, and often women had to cut their care short. Another key area of concern was around the lack of continuity of care. So many women reported poor continuity of care, and they were seeing multiple practitioners throughout their journey. However, those that were able to access continuity of care through existing programs reported really positive outcomes, and it greatly improved their experience with the healthcare system. And whilst we would think that being able to give birth close to home is a pretty standard care of practice, for some women in our region, that's not always the case, and particularly those that were located in Glenelg or in the Colac Otway, particularly in Apollo Bay, they reported having to travel over an hour to be able to give birth. And women in the Southern Grampians region also reported pretty poor access to, services during the pre and postnatal pregnancy phase. All right, we're back with Wilma again, who's just given birth to a healthy child. And whilst the early phases of motherhood are a really joyous experience, it's also been a bit overwhelming for Wilma. It's brought up some underlying mental health challenges for Wilma that she's been battling for a while, but they've really intensified. She's wanting to get support for her mental health, but it's finding it's quite difficult to access care, and particularly difficult to access care in the public health system. She's gone to her local hospital, but has found that she doesn't qualify for the program there and doesn't really know where else to get help. So she goes to her local GP, who's put her on a mental health plan, but it's also a really long wait list to be able to see a psychologist locally. She wants to continue with the physio that she was seeing during pregnancy, but it's too expensive to be able to see a psychologist and a physio at the same time. So she just opts to see the psychologist. She's hoping that she might be able to get a bit more of support through her mother's group to be able to expand her support network. However, she's also finding that a little bit challenging as well. She's had to wait up to 10 weeks to be able to join this group. And recently she's moved out to a rural property outside of Portland. And so the travel to be able to get to that mother's group is a bit challenging, but also the mothers in that mother's group don't live close by, so she's not really able to catch up with them sort of outside the group. She's also seeing her partner struggle for connection during this period, and there aren't really many avenues for him to be able to, I guess, connect with other parents. Lately, she's had quite a bit of trouble breastfeeding and has found it really difficult to get support locally. The maternal child health nurses are quite concerned around the baby's weight gain, and most of the sessions are revolving around the baby and particularly the baby's weight gain. Wilma was hoping that there might be some more checking in on her well-being during this period, and is just feeling pretty overwhelmed and isolated during these early phases of motherhood. And again, Wilma's experience is pretty common, and the stories that you shared with us during this period. So I guess this really positive news in that there's almost universal access to maternal child health services across the Barwon South West region, with 95% of survey respondents stating that they could access maternal child health services. However, some participants did report a desire for more focus on the mother's wellbeing during these maternal child health visits. We know it can be a pretty fragile time, and yeah, mothers are just looking for, I guess, a bit more checking in and sort of nurturing for them. There was also some feedback from some participants who felt as though that some of the information presented by maternal child health was a bit outdated, and there was an opportunity to provide some more contemporary information. However, we also know that maternal child health operates under a statewide framework, and so the visits and the information provided by maternal child health are heavily dictated by the Victorian framework. Mental health support during this period was, I guess, a key theme that arose. So just 33% could access postpartum mental health support in their local area. And as stated, we know these early phases of motherhood can be quite fragile, and accessing formal mental health support is really beneficial and really important. However, many felt though there weren't many options in the public health system, and that those programs that were available had either quite long waiting lists or strict program criteria that left them ineligible to participate. Telehealth was also seen as a really valuable option during this period for those that were unable to access mental health support locally. Social connection, we also know, is a really important protective factor for mothers' mental wellbeing, and parents groups were seen as a really great way to be able to build this social connection. For some, they were able to develop lifelong friendships and was an incredibly valuable resource. However, for others, they found the groups to be a bit inaccessible, and many participants offered some suggestions around how they could improve parents groups. So those things included starting parents groups earlier, extending the duration, connecting those who live closer together in geographical area, and particularly there's a strong recommendation to allow parents who have their second or third child to be able to join these parents groups as a way to connect and make social connections, particularly for those that may be new to the area or just feel isolated. Another strong suggestion was to broaden parents groups to be able to include partners. And it's also really important to provide specific programs and spaces for those who are at greater risk of social isolation. And this was particularly important for those newly arrived communities and the cold communities as well. All right, we're now going to meet our second character. So I'd like to introduce everyone to Sandy. Sandy is Wilma's mum, and Sandy has just turned 50. She's been experiencing a few changes over the past few years or so, but lately these changes have been pretty debilitating. She's currently not sleeping well. She's often waking in the middle of the night sweating. She's been experiencing some pretty severe headaches and migraines, and also some pretty severe muscle and joint pain as well. And so these aches and pains are most commonly felt in the hands and the knees and the hips. Sandy loves to garden, but lately is finding it quite difficult because the pain's having a real impact. The most challenging symptoms, though, have definitely been the cognitive and the mental changes. So she's finding it really difficult to concentrate and is also finding some pretty significant mood changes. So she's been feeling more irritable, more anxious, and angry as well, and just basically not feeling like herself. She's seen her local GP, but they're not super well versed in menopause, and she's feeling as though that she's been left to manage these symptoms on her own. She feels a bit embarrassed to talk about some of the changes that are going on and doesn't really know who to talk to. She eventually opens up to a couple of colleagues at work who are a similar age, and one of them suggests seeing a GP in Geelong who specialises in menopause, and she's able to see them via telehealth. So Sandy's experience is very similar to what we heard from our participants. Perimenopause and menopause was an area which generated a lot of response and a lot of discussion. Our consultations show that there's a pretty low understanding of perimenopause and menopause. Just 18% of respondents said that they had good knowledge. And many participants said that they felt as though they were pretty confused about, I guess, the plethora of body changes that can occur during this time, and they felt pretty unprepared to navigate this sort of, I guess, period or phase of womanhood. There's also a pretty low understanding of where to access menopause support locally. So just only 32% of our respondents knew where to go to get help. Participants described getting care from a local GP, particularly a GP who had understanding of women's health and menopause. Again, this is a pretty consistent theme that we heard throughout, that women felt as though there wasn't a lot of options or practitioners locally who were able to provide them that women's health expertise. So many opted to travel to services sort of, I guess, further abroad that had that expertise in women's health. And again, telehealth was a really useful option for those that weren't able to travel. There are a couple of, I guess, key suggestions during this stage to sort of, I guess, help improve things for women. One of the key recommendations was to help improve awareness building and to provide women with more information around menopause and to really build their health literacy during this phase. There was another recommendation for more, I guess, GPs that had expertise in women's health, particularly in menopause. And another key recommendation or suggestion from participants was, I guess, how valuable workplaces can be. So they suggested for workplaces to provide flexible work options to be able to support women during this phase. And that occurred throughout the consultation, that if workplaces are able to provide flexible working arrangements, whether they're working from home or allowing women to sort of, I guess, alter their start and finish time to be able to suit their needs, even some workplaces providing reproductive leave, that was really valuable. More information to be shared through the workplace. So a number of women reported, there's lots of information around mental health and mental health support at the workplace, but not a lot around supporting women during this phase of life. And also colleagues were seen as a really beneficial source of information and support as well. So women share that they're able to speak to their colleagues who were either going through a similar experience or had already gone through it. And they were able to share, what doctors to see, what medications that they've tried, and different practices to be able to support their symptom management. And we also know that just peer support in general is incredibly beneficial to all women at all phases of their sexual and reproductive health, but particularly beneficial during this stage as well. All right, we're now going to move on to looking at the practitioner's experience. So we'll introduce you to our third character. This is Dr. Amira. Dr. Amira is a GP who practices in Portland. Her expertise is in chronic disease management, so really focusing on diabetes and heart disease. She wants to do more in women's health as she recognises this is a need in her patients. However, it's quite tough to get professional development. It's quite expensive, and any time that she takes out of practice, she doesn't get paid to attend that training. As mentioned, she's a GP in Portland and she already has a really long waiting list. So anytime that she takes time out of practice, that means that she doesn't be able to spend that time with her patients. She would love to be able to bulk bill more of her patients, but financially it's just not viable to run her practice that way. And she's also finding it really difficult to refer patients to, I guess, for women's health issues locally. She's often having to refer patients to specialists who are located in Melbourne. She doesn't have a great confidence or knowledge of those practitioners locally who have a strong understanding in women's health. But she's also finding it difficult to be able to, I guess, find the time to network and to make those connections to other practitioners outside of her local clinic. She's one of the few GPs locally and she's feeling pretty isolated and pretty burnt out currently. All right, and Dr. Amira's experience, again, is, I guess, very much what we heard from the practitioners who we spoke to across the region. So 54% of survey respondents said that they could access professional training opportunities. Many said that there was an abundance of training opportunities, how the challenge was getting to them. So it's really hard to be able to take time out of practice, and also the cost can be really prohibitive. I think the first quote that we can see on the screen really sums up the sentiment that we heard from practitioners. Just 16% of practitioners strongly agreed that they felt connected to other practitioners in the region. Often we found that those that work in sexual and reproductive health and women's health are often the only practitioner in that service, so they can feel pretty isolated. It's also difficult and time consuming to be able to build up those connections with peers outside of their clinic. But those that were able to build those strong connections said it was incredibly valuable and really enriched their experience. So networks and community practices are really helpful, valuable ways to help build those connections and support the local workforce. Nurse-led models of care and also shared care was also two practices and two models of care that were raised as really valuable options. So nurses often have more time than GPs to be able to spend with their patients. You know, they're not bound by these 15-minute consultations and can often have more time to research guidelines and best practice and can do a lot of legwork for GPs. Shared care between different disciplines and practitioners also was seen to work well. So patients might be referred to a nurse or another GP who are able to support their sexual and reproductive health, you know, for example, performing an IUD insertion or helping to manage endometriosis, but the main care is still managed with their regular GP. There's a couple of caveats to that though. So for that to happen, there needs to be that good communication between those practitioners and the services. What was told to us by practitioners that sometimes referrals can often just be, a two-line referral without much information. So there does really need to be good communication between practitioners and different disciplines. But also practitioners need to know who locally is able to perform these services and who has understanding of women's health. So as mentioned before, often women can be referred to a specialist or a practitioner that's outside of the local government area, whereas many practitioners suggested that if they were able to be referred to a local practitioner that does have expertise in women's health, that will mean that women are able to access care more quickly and more cost effectively and also close to home as well. So there's an opportunity to really enhance referral pathways. Because the other key theme that we heard from practitioners is that they're having to spend a lot of their time dispelling myths and dispelling misinformation. So they might have patients that will come to them because they've heard something on TikTok, they've heard something on social media, and they're having to really sort of, I guess, talk through those myths and to provide them with reliable and evidence-based information and to point them through to platforms that will provide that reliable and evidence-based information. Alrighty, we have whizzed through sort of, I guess, the main findings. And we would absolutely encourage you all to jump on our website and to be able to read the report and also the summary report as well, to be able to dig deeper into the findings. But based on the findings from the consultations, we've developed 18 key recommendations, and you'll be able to see that we've got some recommendations for the federal and state government, the local health services and local governments, and also for us here at Women's Health and Wellbeing Barwon South West. So these recommendations will be used to inform our plans and to help guide our activity over the next few years, with the key focus of how can we improve access to sexual and reproductive health care, and how can we make the system more integrated and coordinated. However, as we've heard, we know that sexual and reproductive health care access is multifaceted and we cannot do this alone. So if you're reading the report, if you're reading the recommendations and you feel as though that you have a role to play, or if you have your own ideas of how we can improve access, please get in touch. We would love to chat more and hear your ideas as well. All right, we are now heading, to the phase where a bit more of a Q&A, and to be able to hear from one of our fabulous practitioners across the region. We are fortunate enough to be joined by Dr. Caitlin Pring, who will share some of her reflections and her own experience as we unpack some of these findings a bit further. So Caitlin is a GP with a special interest in women's health and sexual and reproductive health. She has completed additional training, including a diploma in obstetrics and gynecology, and has spent time working in family planning Victoria. She currently works at Cardinia Health as a GP and is the clinical lead in their dedicated multidisciplinary pelvic pain and endometriosis clinic. She also works in the public sexual health clinic, BRASH, which is located in Barwon Health, in the Women's Health Clinic at Barwon Health. So please join me in welcoming Dr. Caitlin, who we are so fortunate to have today. Thank you so much for joining us, Caitlin.
Thanks for having me.
We'll start off with an easy question. Are you able to provide an overview of the Cardinia Health and Pelvic Pain Endometriosis Clinic?
Yeah, so Cardinia Health is a GP super clinic, so has GPs and allied health in Belmont in Geelong. So it's quite a large clinic, and they applied for some federal funding back in 2023. So the federal government provided some grants to 22 clinics around Australia to provide primary care services. So that's GP and allied health services for women and people assigned female at birth experiencing persistent pelvic pain or with endometriosis. And that's recently just been extended for another 2 years, and another 11 clinics around Australia have been brought on board to that program. And so that's allowed us to use some federal funding to try some different service models, because as you've identified, we know that the previous service models haven't really worked for these more complex conditions that do disproportionately impact women and people assigned female at birth. And so we have a wonderful multidisciplinary team, nurses, GPs, pelvic health physios, psychology, dietitian, and a pain educator. And so we all work together to support patients and really try to individualise care to achieve patient goals. We use that funding to support that nurse-led model. So we have our nurses that are the initial point of contact and someone that patients can contact anytime by email or phone on their trusted days. So a point of contact between medical and allied health appointments. We use that funding to support longer GP appointments, so an hour-long first appointment with the GP to really start to unpack a person's symptoms and how it's impacting their quality of life. We use that funding to support professional development for our staff, and also for multidisciplinary team meetings, so a chance for the team to get together and discuss difficult scenarios, share knowledge, really.
Oh dear. All right. It appears that we may have lost Caitlin for the moment.
And
Oh,
can you hear me?
yes, you're back. Yep.
I don't know what's happening with my internet. Can you hear me okay?
Yes, we can. Yeah, good.
So yes, also putting some funding towards group education and peer support, and experimenting now with we've got our GP and nurse doing an outreach session to Aboriginal Health Service just outside of Warrnambool this week. So we're hoping.
Okay, I think we may have lost Caitlin. We'll hope it's just temporary. But as Jacinta said at the start of the session, oh no, we're back. We are back. Great. All right. Sorry, Caitlin. So we were just sort of, I guess, finishing up saying that you were providing some outreach as well.
So one of our nurses and GPs are going out to a service, Aboriginal Health Service outside of Warrnambool this week, and we're hoping that goes well and can be a model we can replicate to other services in West Vic.
Yeah, fabulous. Wonderful. Thank you so much for that. So much of what you shared around your model was, I guess, the gold standard and exactly what we were hearing from the participants in our consultation of what they wanted to see in the women's section of reproductive health care. Women wanted to see a women's health multidisciplinary clinic where they could see multiple practitioners and it to be a really coordinated and cohesive model of care. We also heard from practitioners that it was difficult to be able to access that professional development. So yeah, I guess it's really, wonderful to hear how you're using that funding to be able to support that multidisciplinary approach, but also to really support your practitioners as well. One of the things that we heard was that it's quite difficult for women to be able to access care, but telehealth is a really valuable option. And that some women were unaware of what was available via telehealth and what services offer it. Can you tell us how Cardinia Health utilises telehealth and what benefits you see from it?
Yeah, so we have access we can provide appointments over video link or via phone, and that can be across the board. So nurses, GP appointments, even physio, psychology, they can all be done via video link. And I think that's really important and for that access piece, and has also been really helpful for the check-ins. So particularly our nurse will schedule in check-ins periodically with all of our patients, just to touch base, see how they're going with the plan. Because so often, you wait so long to see a specialist, you get a plan and you kind of leave, and maybe it doesn't make sense, or there are other barriers you hadn't anticipated. So that's been really helpful. Of course, there are some things that need to be done in person, physical examinations, IUD insertions, all that kind of stuff. But we do try to think about how to do that the easiest way possible for the patient. And so we do try to liaise with physios in the West Vic region, but do know that it's an incredibly long wait time, as you've identified. So there are still things that a physio can chat to someone about over a video link, like how to use a TENS machine or talking through some breathing exercises. But yeah, obviously some things still need to be done face-to-face. Traditionally, there have been limits in, what you can do because of Medicare funding, but there are now, Medicare item numbers to support providing these services without the same requirements to see people face-to-face. So, yeah.
Yeah, fabulous. Great. Yes. I guess one of the things we heard is just participants being surprised is how much information and how much support can be provided by telehealth. So
Yeah.
Wonderful. I do know you'd see patients all across the region as well.
Mm.
So we spoke quite a bit around women's pain being dismissed, and we saw through the Victorian statewide women's pain inquiry that's a pretty, common sentiment that women have felt. What has your experience been treating women with chronic pain and their experience of, seeking help as well?
Yeah, I think it's a really unfortunately common story that you get people coming in and they've felt dismissed or gaslit, not known where to turn to. And it's I think having the hour-long initial appointments with a nurse and then an hour with a GP is so therapeutic in itself to be able to really explore the symptoms and not just start thinking about the potential contributors to those symptoms, but also the impact on that person and what it's doing to them and their family and their work, and just acknowledging the load that so many people have been carrying up until that point, not just physically and emotionally, but financially and the time burden and all of that as well. And look, I think a lot of that is reflective of a system that doesn't support this type of care. And so I don't think it's that any GPs or health professionals intend to dismiss women's pain, but, traditionally the research hasn't been there, the education in medical school hasn't been there, the setup of GP appointments with the focus on 15-minute medicine is just, it's not possible to do the kind of care that you need to. And I think what we've really noticed as well is that it extends beyond pain. So many of our patients suffer fatigue, other whole body symptoms, other chronic pain conditions, neurodivergence that's been undiagnosed, POTS, dysautonomia, chronic fatigue syndrome, all of these more complex conditions that no one can possibly deal with in a 15-minute consult, and that really do take time and a dedicated team to go on that journey with someone. And so, again, it's a huge burden on the patient to have to find that team. And then usually it takes time to unpack these complex overlapping symptoms over time and trial different therapies and see what works. And so, yeah, it's been really rewarding to be part of a team and to be able to allow women that space and to have the time to build the trust so that they know that, we as a team are committed to going on that journey with them.
Yeah, wonderful. Yeah, that's really, really lovely to hear, and sort of, I guess, something that we definitely experienced during this consultation, that, we would speak with women for about 45 minutes an hour, and they reported how therapeutic it was to actually share their story and to feel believed. But also on the flip side, we heard from, practitioners that said it's really difficult to be able to build rapport and to build trust in 15 minutes. And you're often speaking about something that's, been impacting the woman for many years, but also there might be some shame or some stigma around sort of to bringing up. So, yeah, really wonderful to have that safe space and that dedicated space to support the care. Another, I guess, key theme that we heard was around, I guess, information during sexual reproductive health can be conflicting. It can be overwhelming. As we said, some women have felt sort of, I guess, gaslit and not heard by the medical sort of, I guess, practitioners. They might jump onto sort of, I guess, social media and to hear conversation around that. I think social media has been great in generating conversation, but we know it can sometimes spread misinformation. What do you suggest to sort of, I guess, help build patients' health literacy around sexual and reproductive health? And is there any sort of, I guess, resources, science that you recommend to your patients?
Yeah, so our website is currently being sort of redeveloped, so it's looking a bit funny at the moment, but we do have a resource page on our website with links to what we consider some trusted resources. So there's some really fantastic websites and social medias. So from an endopelvic pain perspective, the Pelvic Pain Foundation of Australia has some really excellent patient information. QEndo is an excellent resource and has a lot of peer support and advocacy work. Jean Hales is a good general women's health website. Online, it's a really challenging space though. So I think it's just being conscious of the content you're engaging with, thinking about, who's putting it forward or who's funding that content. How does it make you feel?
Yeah.
Is it trying to sell you anything? And, I think peer support is so important in this space. And so there's lots of groups out there that can be really helpful to feel less alone and to get advice and ask questions of. But just being conscious again of how it makes you feel interacting with those groups, because, you know, vicarious trauma is also real. And if you're a part of online support groups or following certain pages that might post things that are upsetting to you, just being aware of that and how much you can engage with those spaces. Yeah.
Yeah, beautiful. Great. Thank you so much, Caitlin. That's all been fascinating and very helpful for me, and I'm sure very helpful for all the people on the call today. We'll now open it up to be able to, for the audience to be able to ask any questions. So you can ask any questions to myself, to Jacinta or Caitlin. Feel free to pop a question in the chat or in the Q&A button there. I've seen that we've got one question come through, and I believe it's for you, Dr. Caitlin. So we've had an attendee ask, is there any cost involved at the Kidinya Health Pelvic Pain Clinic?
Yeah, so unfortunately the funding does not go as far as we would like. There is an initial registration fee, so $125 or $100 for concession card holders, but that then covers sort of unlimited nurse support, an hour-long appointment with a GP and an hour-long appointment with a member of our allied health team, plus access to all of the group education and some pain flare plan sessions and things like that. So it's a reasonable amount of service that you get for that $100. Most people find that they need more than that initial contact, though. For managing persistent pain, often it is multiple physio, psychology, dietitian appointments, and that's a huge barrier for us, and something that we're advocating for is that there needs to be better Medicare funding and better public access for allied health services. Because we try to bulk bill as many GP appointments as we can, particularly for concession card holders, but it's those specialised allied health appointments that are costly, and if we funded all of them for everyone, we wouldn't be able to provide services to as many people, and so that's a real challenge for us. But where finances are a barrier, we really encourage people to reach out to our nurse directly to discuss, and we do also link in with public services where available. That's obviously a lot easier in Geelong, where we have public pelvic health physio services and dietetic services. I know it's more challenging in West Vic, but we do try and link people with appropriate services if there are financial barriers.
Yeah, beautiful. Great, thank you. Caitlin, we've got another question that's come through. This one's a big one, so good luck answering. And Jacinta, if you want to answer this one as well, feel free to go for it. If you could wave a magic wand to make one change today to improve sexual reproductive health care in our region, what would that change be? I'll hand that to you, Caitlin and Jacinta.
Wow. Oh God, there are so many things, but I think if I had a magic wand and I was thinking bigger, it really needs to be sort of a whole of society change, right? Like, so much of the initial barrier is women feeling shame or told that their pain isn't real, or that this is sort of part of their lot. And so I think if there was just this general change in societal attitudes around these symptoms and conditions that affect women, and that women weren't afraid to come forward, or women weren't afraid of being dismissed, that would be hugely beneficial. Yeah,
the big one. Yeah, awesome. Thank you,
Caitlin. I have to agree. I think for me, if I had this magic wand, it would be for women to have the acknowledgement and the experience that sexual and reproductive health is just an essential part of their general health care, and it was normalized and talked about in the same way that any other kind of physical or mental health condition, and that women felt like that it's something that they could access care to readily in the way that they need it, and in a way that meets their needs, I think.
Yeah, beautiful. Terrific answers. Thank you both. We've got another question that's kind of in similar vein, and I'll get both of you to share your thoughts. What message would you like all women to hear about sexual and reproductive health?
Again, I think it sort of ties back in that, as Jacinta said, that it is a crucial part of health and well-being, and I think so often women, people assigned female at birth, put their needs after others. And again, we could go into all of the psychological and socio-political elements underneath that, but feeling like you deserve that time and that care, and that it is important, and that it is a part of your overall health and well-being. Yeah, I think is, and moving beyond just the absence of disease to actually thinking about sexual well-being as well. Like, it's not just about things not hurting or things not giving you grief, moving towards feeling positive and enjoying good sexual health as well.
Yeah, beautiful. Thank you. Jacinta, any thoughts from you?
I don't think I can top that at all. I think absolutely here. The acknowledgement that this is normal, this is part of your life. You should have great sexual and reproductive health across the entire life course. Yeah.
Yeah, beautiful. We've got another question that's specific to Kidinia Health. So, Caitlin, is there an approximate wait time associated with accessing an initial appointment at the pelvic pain clinic?
Yeah, so we're actually doing really well at the moment. So anyone can self-refer. You don't need a diagnosis of endometriosis to access. Any kind of persistent pelvic pain is welcome. So you can self-refer via our website. We do have quite an extensive questionnaire to fill out first, just so we can sort of hit the ground running, but then you can book in your first appointment with our nurse, which you can usually get in within a couple of weeks. You see our nurse, she explains our service, gathers all of your information, and then books you in. She kind of will try and pick the right GP for you, and book you in with your first GP. And that can usually all happen, within a few weeks. Obviously, being a service we're really only there a day a week. We're not an acute medical service. So if anyone's ever experiencing sudden, severe, acute pelvic pain, we really recommend they see their local GP or present to an urgent care or emergency if they're worried. But yes, for that longer term persistent pelvic pain management, we can get people in within a few weeks at the moment.
Yeah, great. That's very exciting. Yes, wonderful news.
And I should say as well, I'd really welcome any feedback. So part of our funding model is we're getting a very, very small amount of additional funding from next financial year to provide perimenopause and menopause services.
Okay. Yeah.
And so really welcome any feedback or ideas from both practitioners and member of the public that are here today. Can reach out via our nurse email, which is just pelvicpainnurse@kidneyhealth.com.au. And that's available on our website as well. Or if anyone has any questions or ideas or wants to discuss outreach to their region, please feel free to email us.
Beautiful. Great. Thanks, Caitlin. I've got another question, and this one might be for all of us. So the report highlights a number of barriers accessing and providing care. In your experience, are there barriers that don't always show up in the data but you see affecting patients every day? So would you have any sort of, idea of barriers that might not show up in the data but you do see affecting patients, Caitlin?
Yeah, so I think aside from the financial burden and how that holds people back from care. I think the time burden as well, and so how people are supposed to juggle multiple allied health appointments during business hours while they're also working and caring for children and caring for parents and all of those things. It's just such a huge time burden as well. We do try and track data on absenteeism and presenteeism, which is sort of a challenging to measure as well. So it's not just that women are missing out on work or study, but when they're there, they're not able to necessarily give their best because of their pain or pelvic symptoms, and that's a real challenge as well. And then I think so many of the other conditions that we see alongside pelvic pain and endometriosis, as I said, some of these other conditions that are a little bit harder to define or, again, not as well addressed in our medical system, like chronic fatigue or POTS or neurodivergence. I think the impact of all of those conditions together is just huge, and I think it's hard to quantify just the degree of burnout that people suffer.
Yeah, totally. Yeah, you've got to be quite committed and quite proactive. Jacinta, any thoughts from you around sort of, I guess, other additional barriers that might not show up in the data?
Not necessarily, but I think referring back to our original systematic review is a really useful tool for looking at that. That review really looked at all of the barriers and challenges in accessing care, and it speaks to those compounding factors of if you have to travel really far, but you work full time and you also have caring responsibilities, and what all of those things look like. So I'd encourage people to jump on our website and have a look back at that review and that original mapping report that was done in 2024, because I think it speaks to some of those kind of compounding issues that women and gender diverse people face, particularly in regional and rural areas where things like rurality and the impact of that are often underestimated.
Yeah, beautiful. Great point. Thank you. Yeah, the other thing that comes to mind for this question is Jacinta mentioned at the start that there were some, I guess, population groups in our region that were, I guess, underrepresented, or maybe sort of, I guess, didn't share their voice as much during the consultation. So First Nations, cold communities, we didn't hear from their voices as much as we would have liked to. However, as Jacinta pointed out, that literature review does acknowledge that cultural safety is really important during healthcare, and can sort of, I guess, determine whether a person even steps inside the door of a health clinic if they feel culturally safe to do so, and if they feel as though they're going to be met with care and empathy and understanding from that healthcare practitioner. So that was something that we didn't, I guess, capture a lot during this consultation. However, we know from, I guess, broader literature that, I guess, having an inclusive and welcoming, I guess, healthcare provider that will support, a person's background is an important determinant of care. We've got another question here around sort of, I guess, practitioners' wellbeing. So what can we collectively do to reduce burnout in this space? Given the wait list, the difficulty recruiting in regional areas, we don't want to lose more skilled practitioners in this space. Caitlin, do you have any thoughts on supporting practitioners' wellbeing?
Yeah, so again, this is where I guess the funding through Cardinia Health and this project has been hugely rewarding and sustaining in what is really challenging work that tends to find you as a female GP anyway. And I should say, like, it's a privilege, and it's I really appreciate that women feel safe to share their stories with me. But yeah, it can be really challenging in terms of time and vicarious trauma and things like that. But through this program, we've been able to link in with other clinics around Australia, and so we do have monthly webinars and a WhatsApp and that peer support piece. And again, having the funding to support our team to get together once a month and debrief and support each other has been hugely helpful, but not something that in general GP work you would normally have access to. In Geelong, we're very lucky. We have, again, some informal WhatsApp groups for people, practitioners interested in pelvic pain. So, yeah, if anyone on this webinar is sort of Greater Geelong based that wants to join up any pelvic health support groups for practitioners, please let me know. And so even just recently, we had some members of that group host a yoga session just for practitioners working in the space. And I know that was really well received. But again, these are all things that sort of happen outside your regular work hours and can be really challenging. I know RACGP has a number of special interest groups for GPs, and again, WhatsApps where you can share difficult cases. So I think there are more informal WhatsApp groups and things out there. It's just a matter of knowing who's around and finding them. And I imagine that is really challenging further afield in West Vic.
Yeah, totally. Yeah. Jacinta, any thoughts from you around that, I guess, workforce connection?
Yeah, absolutely. And this is something that we identified quite early on here at Women's Health and Wellbeing. That was an issue when I was going out and meeting with all of these practitioners who are incredibly passionate people, often working quite isolated, like you said, referred to in the data, Caitlin. A lot of the sexual and reproductive health practitioners that we come across are solo operators within a service and are really driven and rely on their passion. One of our concerns was exactly this: how do we support this workforce and make sure that these wonderful individuals don't feel burnt out? And so a little bit of a plug for our sexual and reproductive health community of practice. It's a group of health practitioners with an interest in sexual and reproductive health that meet, Caitlin, you'll have to correct me if I'm wrong, but every 2 months online, with a couple of in-person events each year as well, really with the idea around sharing practice challenges, getting to know each other, building connections, and providing that support to each other in this space in which is quite a challenging, as you said, Caitlin, quite a challenging area of health to be supporting women and gender diverse people through. So Caitlin, I think we'll share some more details on that community of practice shortly.
And one of our pelvic pain nurses also if there's any nurses on the session, she also runs monthly nurse community of practice for anyone working in the pelvic pain endo space.
Oh, wonderful. Yeah, great. Thank you.
So again, reach out to our email.
We'll do. We've just got one more question before we wrap up, and I might direct this to you, Caitlin. So could we develop, or is there a perimenopausal menopausal care plan like we have with mental health? Then could it be linked to other support care plans?
So there have been changes. So there's a couple of Medicare supported plans that are available through your regular GP that can help reduce costs of allied health. And so, mental health care plans are largely for psychologists, but also can be used for mental health OTs that can be really helpful. What used to be called a GP management plan is now called a GP chronic condition management plan. And so it's a little bit the criteria to use that has sort of expanded a little bit. And so I do find that most people coming in with perimenopausal symptoms, there's often lots of things going on, and you might be able to use one of those plans to access some allied health support. And so unfortunately, that's only 5 sessions a year that you can access through that plan, and it's not as much of a rebate as a mental health care plan. And so again, I would love to see the government increase funding for those plans specifically. And thinking about, again, with telehealth, I think there are increasing numbers of telehealth services now available that are a bit more affordable in the women's health space. So I know there's a virtual health women's clinic that the Victorian government has supported that's now up and running, and they are bulk billed telehealth services with the GP at least. And there are some other clinics that are open up much cheaper, like dietetics, telehealth services and things like that. Yes. Was that the original? You might have to remind me of the original question.
Yeah, no, that you've answered that
On
well.
a tangent there.
We're running close to the end, so I think we'll wrap up the Q&A part there. But thank you all so much for your fabulous questions. We'll just do a quick wrap up now that we're at time. So Soldo, if we want to move back to our slides. Beautiful, thank you so much. So there's just been a couple of, I guess, information shared today. So Jacinta has mentioned that Women's Health and Wellbeing Barwon South West, we want to run a sexual and reproductive health community practice that's open to all practitioners that are interested in sexual reproductive health across the region, whether it be a physio, whether that be a nurse, whether that's being someone involved in research or education. We meet bi-monthly, mostly online, but a couple of face-to-face sessions. Would love to have you there. Feel free to reach out to us if you'd like to know more information. We have whizzed through today's findings. So we're very happy to deliver a presentation, whether that be to you or I guess a network or a team meeting, to be able to unpack these in more detail. Again, feel free to reach out to us. We'd love you to read the report. I believe Isolde has put the links to both the summary and the full report in the chat. And feel free to get in touch if you have any queries or if you have any comments. And finally, just a brief plug for a lived in living experience advisory group that Women's Health and Wellbeing Barwon South West has recently released. If you jump onto our website or our social media, there'll be more information around that group, but it's really an opportunity for those living in the region that do have, I guess, a lived experience of broad women's health issues, to be able to get in touch and to share their experience and to help inform our work as well. Huge thank you to you all for joining today. We greatly appreciate your interest and support with our work. We absolutely cannot do this alone, and really appreciate everyone's interest in this really, I guess, important and often, I guess, issue that's not spoken about nearly enough. And a huge thank you to Dr. Caitlin and also Jacinta for presenting today, and thank you to Isolde for all the tech support. Here are our contact details. Again, don't be shy. We'd love to hear from you and to help continue on these conversations. Thank you, everyone.
Did you see that, Dr. Caitlin Pring? We'll just leave and then we'll come back in. I think she's frozen.
Yeah, I think she's frozen. Okay, we'll end now. How do I end? There we go.